Should everyone be taking colchicine in order to prevent heart attacks? That's the kind of question we see answered in the January 2022 CFP Journal. And here at CFP Distilled every month, we take a look for those pearls, things that you need to know if you're studying for the CCFP exam or for clinical practice in family medicine in Canada. So in addition to that, we've got guideline updates this month. We've also got some articles on COVID-19 induced vaccine injury in children, specifically myocarditis. So let's take a closer look. Does colchicine prevent heart attacks? Well, the answer is yes, but there's always a condition. So what are the conditions? Well, first of all, the studies are talking about folks who have coronary artery disease. We're talking about secondary prevention. Also, the studies show that there's about a 1% risk in reduction of cardiac events. We're talking myocardial infarction and the like. But there's also side effects. That's 2% of people are going to have gastrointestinal side effects. And what's the mortality benefit, you may ask? There isn't any.
Rapid recommendations from 2020 from Danielle O'Toole. So this is part 2. Where are we going to concentrate? We're going to talk about the lung. So a combination treatment of ICS and formoterol for both prevention and controller therapy for patients over the age of 4 years old for asthma. What else are we going to do? We're going to remember that glucocorticoids and antihistamines are no longer a part of the treatment for anaphylaxis.
So a child comes to your clinic, they've just had the COVID-19 vaccine. They're complaining about chest pain, shortness of breath on exertion, or palpitations. What do you need to think about? That's right, we're thinking about vaccine-induced myocarditis. It's rare, it's nowhere near as common as in people who do get COVID-19, but it's something we need to consider. What are your next steps? History, physical, and they're gonna need an ECG and a troponin to rule out myocarditis, so make sure you send them on to the emergency room so that they can get those done today.
What are the other key recommendations in the second half of this part 2 article from top recommendations in 2020? It's to go with the mind. So the first thing is, what if you have a patient and you discover covert infarcts on imaging? Well, you can consider a recommendation for ASA in those patients. Now, what about that workup for mild cognitive impairment or dementia? Things that we want to ensure we check. We want to check hearing. We want to check, are they sleeping well? Is there insomnia? And is there frailty involved, neuropsychiatric symptoms, and gait speed? We want to check all those. What about patients who've already been started on memantine or cholinesterase inhibitors? When use exceeds 12 months and cognitive decline has been going on for 6 months, consider stopping those medications.
Thanks for watching the January 2022 CFP Distilled. My name is Dr. Simon Moore. Now, if you're studying for the CCFP exam, please take a look at thereviewcourse.com, where we've compiled all of our best tips and tricks to help you prepare for the exam. Hope to see you again next month in February 2022. Hi, it's Dr. Simon Moore from the Review Course in Family Medicine. It is February 2022. Let's take a look at the most clinically relevant articles in this month's CFP Journal, like we do every month here at CFP Distilled. The Canadian Pediatric Society's got 7 P's that they ask us to use when we speak to pediatric patients about their sexual history. Number 1, get permission. 2, past medical history. Then we're going to find out about condom use. That's things like pregnancy as well as protection from STIs. We're also going to talk about the partner as well as the sexual practices, and finally ending up with number 7, which is the person's personal identity.
Some of you might have seen and heard about oxytocin used intranasally in autism spectrum disorder. What's the actual evidence? So there's no clear evidence that it helps in children. However, in adults, there may be some improvement. There's a great article if you want to read more about this emerging area of literature in this month's CFP Distilled.
For your patients with osteoarthritis, think about asking them to do low-impact exercise in addition to weight loss from diet. There was many multiple controlled trials with hundreds of patients. They looked specifically at this. Diet alone doesn't give you the pain relief for osteoarthritis. It's got to include low-impact exercise as well.
Daily vaginal progesterone is recommended to start between 16 and 24 weeks in women who have a history of preterm birth or a shortened cervix, and this should continue on through 34 to 36 weeks.
The Review Course in Family Medicine is back to being live in person. We took a hiatus, we went virtual for a couple of years, but now we're doing courses. Here are pictures from Calgary, from Vancouver. We also have an upcoming course in Toronto in March. So if you want a live, fast-paced, energetic, in-person review of the 1 of 5 topics, check out thereviewcourse.com. That's it for the February 2022 CFP Distilled. So glad you could join us. Check out thereviewcourse.com for more information about CCFP exam prep and staying up to date as a Canadian family physician. This is a very exciting month for CFP Distilled. I'm going to tell you why I dressed up for this special occasion. We've got one of the guideline authors as a special guest this month. It's March 2022. There's a brand new chronic pain guideline in this month's CFP Journal. There's concussion tips. There's rapid fire pearls, and every month we take a look at the most clinically relevant articles that you need to know for the CCFP exam or for clinical practice and distill them down. You're in the right place if that's what you want here at CFP Distilled. Great clinical pearl for those patients who come in with a single swollen leg. You're worried about a DVT, so what's your first test? The Thrombosis Canada guidelines say if they're high risk, go directly to ultrasound. And this case report shows why. A 76-year-old guy came in with DVT symptoms. The D-dimer was negative, yet the ultrasound still continued to show a clot. So if you're worried about a DVT in a high-risk patient, you can skip the D-dimer, go straight to ultrasound.
Kids and head injuries. The Canadian Pediatric Society recommends a skull x-ray, but when kids have a large body hematoma and you need to decide, do we need to CT this child or not, using the PCARN or CATCH-2 rules. So add that to your arsenal of tools. Consider you doing a pediatric skull x-ray if there's a large body hematoma to reduce the overall radiation risk while using those other tools.
A clinical pearl for you. For your folks with recurrent cellulitis, they've got chronic leg edema. Which intervention can you do to prevent cellulitis from happening again? An RCT with 84 people found that compression stockings reduce the incidence of cellulitis from 40% down to 15% in just 6 months.
Best of luck for those of you still studying for the exam, and don't forget, you can watch our videos online if you attended the courses here right up to the examination.
All right, so I know I promised you a special guest. One of the authors of this month's CFP Journal articles is here in the CFP Distilled studio. That's right. I'm one of the folks who helped write the chronic pain guideline from the peer group. I'm really excited that they invited me to be a part of this group, and I might not be invited back because I'm not authorized to speak on behalf of the group, but they've always put out phenomenal guidelines. There's no industry sponsorship, and this month's guideline is on chronic pain, specifically osteoarthritis, low back pain, as well as neuropathic pain. Now, there's way too many other conditions and way too many individual drugs, and they did a literature review for each and every one of these. And it's amazing how they were able to summarize all that content and put it into a single page. So take a look at the resource here. By far and away, the best treatment, needless to say, is exercise. It's nice to know that the evidence still supports that. So what about the individual conditions? We want to take a look at osteoarthritis first. Take a close look. Intra-articular corticosteroids, very effective. SNRIs are really good for osteoarthritis, as well as the other two conditions studied in the guideline. So I hope you find this summary helpful. I hope you find this guideline useful. Fantastic guideline from the peer group on chronic pain.
An interesting article in this month's CFP Journal that compares return to learning and return to play. So two aspects we need to consider when you have a child and patient post-concussion going back to activity. So two areas to consider. What it turns out is we've been pretty good at return to play recommendations, but when we think about return to learning, we may be even sending people back a bit too early. There's a stepwise algorithm for return to learning that maybe we should use a little bit more.
Thanks for joining us. I hope to see you next month at CFP Distilled. As always, check out thereviewcourse.com. If you're studying for the CCFP exam, we've just announced our 2022 summer dates. If you're writing in fall 2022, or if you want a head start studying for the 2023 CCFP exam, check out thereviewcourse.com. See you there. Spring has sprung, and so is the April 2022 edition of the CFP Journal. So if you're practicing family medicine in Canada, or if you're studying for the CCFP exam, you might want to know what are the most clinically relevant articles in this month's edition. That's what we do here at CFP Distilled. We're going to look at pointers on peripheral artery disease, pointers on kids with long COVID, kids with a blistering diagnosis, and there's another mystery diagnosis that the research says you and I are not good at picking up on. So let's find out what that is here at CFP Distilled.
Long COVID in children. What do we know so far? No great evidence-based guidelines. A lot of the research is just case reports and case series. But what can we offer to our patients? Well, we can offer close follow-up and treatment for the symptoms of long COVID in children. And what is that? There's fatigue, it can be headache, it can be joint muscles, aches and pains. So remember to keep treating the symptoms while we wait for more evidence-based guidelines.
So what could this diagnosis be? A patient comes to see you and they have cancer. They're in palliative care and they are complaining of a sudden increase in pain, confusion, hallucinations maybe. You go to examine them closely. Light touch causes extreme pain. They've got allodynia. And then when you look more closely at their muscles, they've got myoclonus and tremor. And if we don't catch this diagnosis early on, they could end up with seizures. These are the diagnostic criteria for opioid toxicity. When patients are using an opioid and it has metabolites, and these metabolites build up and cause these severe adverse drug reaction symptoms. So how do we manage this? First of all, make sure we identify it. The research says you and I are not good at picking up on this diagnosis, so let's try and improve that. Secondly, we're going to try and increase hydration. Third, reverse whatever could be causing it. Perhaps they've got a renal issue that could be reducing their clearance of the metabolites. And finally, consider reducing or switching the opioid to something else.
Chronic bullous disease of childhood. Not all rashes are infectious. Consider this in your next diagnosis when you look at a childhood rash. Now, what are we going to do for these patients? Clinically, we're going to look for the string of pearls sign. The string of pearls sign. And what are we going to do? We're going to do a biopsy. After we get the results, we can reassure our parents that this particular disease is not infectious. Treatment can involve colchicine, steroids, and NSAIDs, and probably referral to a dermatology, especially if you're writing that CCFP exam.
Are you studying for the CCFP exam in fall 2022 or spring 2023? Well, then you might be interested in joining us at the review course in family medicine. Mark your calendars. We are going to be in Toronto on September 10th and 11th, 2022. Hope to see you there.
Exercise. It's not only good for you and me, but what about your patients with peripheral arterial disease? Yes, it can improve maximum pain-free walking distance by up to 200 meters for your patients who use some form of exercise therapy. Multiple RCTs have confirmed this. No change for mortality or amputation, but you can increase the duration and how far they can walk pain-free. So remember to offer that to all of your patients.
May 2022 has another edition of CFP Journal coming out. Don't miss CFP Distilled that month by subscribing. We hope you enjoyed this and we will see you then. Take care. My name is Dr. Simon Moore. We are at CFP Distilled right now, and every month we take a look in the CFP Journal to find the most clinically relevant articles for you if you're studying for the CCFP exam or if you practice family medicine in Canada. So this month's articles: budesonide in COVID-19, top articles from 2021, tympanostomy tubes in kids, plus a bonus article on what to do, what to expect, and what to be aware of if you are a family medicine resident and planning to be pregnant.
Tympanostomy tube placement for kids with acute otitis media. What's the best evidence? What do you do? First, some definitions. So, what is recurrent otitis media? When do you have to refer for treatment? Well, if it's more than 3 in 6 months or 4 in over 6 months, that's when you're thinking about a referral for tubes. But what's the best? What's the final answer? What's the line? Well, it can be a combination. Tympanostomy tubes decrease incidence, but over 2 years using intermittent antibiotic therapy, watchful waiting, and or tubes, everything's equivalent at 2 years. So consider all of those options when you're treating those cute little kids with acute otitis media.
For your patients with COVID-19, if they've got one or more comorbidity, consider prescribing them budesonide. This inhaler, 800 micrograms twice a day for 14 days, reduces the length of illness by about 3 days, from 15 down to 12 days. It also reduces the chance that your patients are going to need to seek care from 59 down to 53%. The May 2022 CFP Journal has an article on the top articles from 2021. Let's take a look.
What's one of those top 10 pearls for primary care? Low dose ASA for those women who are at increased risk of preeclampsia reduces their risk of preeclampsia. So think about low dose ASA in those patients.
How do you spell success when it comes to heart failure? Well, when it comes to your patients with mildly reduced ejection fraction, we're talking 40% or less, consider giving them an SGLT2 inhibitor. SGLT, I guess, is the answer to how do you spell success. The reason being, there's a number needed to treat of 31, which is pretty solid at reducing cardiovascular outcomes such as hospitalization or death, according to a trial with 6,000 patients.
Delayed antibiotic prescribing for upper respiratory illnesses. The evidence is in, and delayed antibiotic prescribing doesn't result in any negative outcomes and potentially less antibiotic resistance when we're thinking about that big picture of public health.
Turns out that flimsy, floppy, flabby, flat footwear is not a good idea in osteoarthritis. Those patients are going to have a little bit of pain reduction, 1 out of 10 on a scale of 10, but if you give them a supportive shoe, a firm-soled shoe, something with arch support and heel support, their pain reduction goes down on a scale of 1 to 10 by about 2.
Is semaglutide the super drug for obesity? Well, people will have reduced weight while on the medication. However, that's not consistent after they stop the medication. So it does work right now, just in the short term, and you've got to keep on taking the medication. Another one of the top 10 pearls for family medicine.
What's it like being pregnant while you're a family medicine resident? That's the question that these researchers asked in another article in the May 22 CFP Journal. They found there's 3 phases. The first phase, being pregnant at work, has its own set of challenges. The second phase, being a brand new parent at home on leave. And the third phase, they found the most challenging phase, was being back at work, the transition into practice, being off cycle, having difficulty finding spaces in the hospital to pump or breastfeed, and then coming back home and being torn between the challenges of work and a brand new family. So that was a fantastic article in the CFP Journal. Now we've got a pro tip for you. If there's any chance you'll be breastfeeding or pumping when you write the CCFP exam, make sure you declare this and ask for an accommodation at the time you register for the exam. That's very important. It must be done at the moment you register for the exam. If you show up on exam day looking for a breastfeeding fridge or looking for extra time to pump, you're not going to be given that extra accommodation. So make sure you request it at the time of the exam. That's the CCFP's policy.
Tickets are on sale now for a virtual and in-person option in Toronto in September of this year. So for those of you considering getting an early start on your studying, you can sign up now at our early bird rate.
From asthma to acne, from babies to bronchiolitis, June 2022 CFP Journal has got it all, and here we are at CFP Distilled. We're going to cover the most clinically relevant articles in this month's edition. I'm Dr. Simon Moore from the Review Course in Family Medicine. Stick around, we'll show you these articles, and we've got news about our summer course. See you there.
What goes better together for treating mild papulopustular acne than tea and biscuits? Well, it's combination treatments. When considering the treatment for mild papulopustular acne, don't forget first line, topical retinoids and benzoyl peroxidase, second line, OCP and isotretinoin.
Beta-2 agonists in babies with bronchiolitis. If you are looking for a CCFP crash course on bronchiolitis, this article is a good one. Buckle up, let's dive in and take a look. So, turns out that giving a medicine that treats wheeze doesn't help the wheeze in bronchiolitis. So why is that? In asthma, beta-2 agonists work. They relax the smooth muscle constriction. So the smooth muscles that are tight in asthma, you give a hit of beta-2 agonist, salbutamol, and they inhale that and the muscles relax. But the mechanism of wheeze in bronchiolitis is completely different. It's a different mechanism. It's caused by respiratory epithelial cell sloughing. It's caused by inflammation, mucus in the airways. It has nothing to do with smooth muscle constriction. And for that reason, the beta-2 agonists don't work. Could you list on an exam some reasons why we don't want to give them? You can get side effects, tachycardia, irritability, flushing, tremors, and it's also been shown to reduce oxygen saturations in some patients as a side effect. So make sure you're considering giving the treatments that are effective for bronchiolitis. There's lots that work really well and lots that don't, and you should be able to list these on an exam. So what are the ABCs of treatments that do not work for bronchiolitis? A is for antibiotics. They don't work. B, beta-2 agonists. C, corticosteroids, and a bonus one, E, epinephrine or racemic epinephrine, also shown to be ineffective for babies with bronchiolitis. So if you've got an exam question and there's a child with bronchiolitis, they come into your clinic, how do we manage them? We're going to use supportive treatment. We're going to treat them with hydration. We're going to manage their secretions with suction if needed. And we're also going to make sure that we are supporting their oxygen saturations. Supplemental oxygen if they need it, if they're getting hypoxic. So that's management of bronchiolitis in a nutshell. Fantastic article. Take a look in this month's CFP Journal.
How important is pulmonary function testing for the diagnosis and management of asthma and COPD? Turns out it's really important, but we're not doing it enough. 30, 40%, sometimes people don't have their official PFTs even a year after diagnosis. So what happens to these people? Well, it turns out we're over-diagnosing COPD and asthma, and then we're underestimating the severity of COPD. So you need to get those PFTs. Guidelines recommend everyone over the age of 6 should be getting their PFTs. So don't forget this really important investigation.
So 7 years ago, Dr. Paul Dillon and I started the review course in family medicine. There was nothing like it on the market to help people like you prepare for the CCFP exam. And so that's why every spring and summer, we go across Canada to help people prepare. This summer's offerings, I've listened to you, we've listened to what you want. People have asked us, we want an option for more streaming, for longer streaming options. So we've got a virtual course and you can choose the length of streaming if you want to come and see us in person at the Review Course in Family Medicine, Toronto, summer 2022. We will be there. We are bringing our high energy faculty. We've got our high yield tips, tricks, and exam preparation strategies. We'll cover them all. I hope to see you there in Toronto, summer 2022 at the Review Course in Family Medicine.
Binge eating disorder was added to DSM-5 in 2013. So what is binge eating disorder? Well, you have a feeling that you're losing control and eating an abnormally large amount of food over the course of 1 to 2 hours. In terms of male to females, think about that 1 to 2 hours, but flip it. It's more common in males in a 2-to-1 ratio. It puts people at higher risk for hypertension, diabetes, and a number of other conditions. So what can you do for these patients? Well, they're pumping away. Guided self-help, pharmacotherapy in a stepwise way. That's what you need to remember for binge eating disorder.
There's a case report in this month's CFP Journal about the NRP guidelines failing this group of clinicians. They were stuck, they were stranded, they didn't know what to do. They got to the point in the algorithm and then they got the treatment. The coolest conclusion, the treatment for this child's case was ice cold. So what happened? A child was born unresponsive and they went through the algorithm. If you want to memorize NRP as easy as possible, this is your 2 mnemonics you need to know. Number 1 is tone, tears, term. You walk into the room, you check the baby's tone, you find out, are they crying? And you find out what is their term significance? Are they preterm, term, or post dates? Then for each branch point in the algorithm, the other mnemonic you need to remember over and over in your mind, breathing, beating, blue. Is that what's going on? Great pediatrician in Nanaimo, BC taught me this trick because if there's a problem with one of those 3 areas, you've got to adjust something. If they're not breathing adequately, if their heart isn't beating adequately, or if they're cyanotic, if they're blue. So then you adjust things, and they did that for this baby. They adjusted positioning, they stimulated, they gave adequate ventilation and oxygenation, but there was still poor perfusion. How can you measure poor perfusion? You should be able to write this down on an exam. Well, they found that the pulse was weak and thready, and they also found that the cap refill was prolonged. It was more than 4 seconds. So they did an ECG, got a hemoglobin, tried to find out what is going on with this baby because the NRP algorithm doesn't really help much for a child who is hypoxic, who's got a weak and thready pulse, but their heart is fast. There's lots of tips on bradycardia, but not for tachycardia. So the ECG showed a heart rate of 278 beats per minute. This child was diagnosed with supraventricular tachycardia. They called the neonatologist. They said, we're getting ready to cardiovert the child, either with adenosine, you should know the dose, 0.1 milligram per kilogram, or with an electrical cardioversion. Again, another dose you should know, so 0.5 to 1 joule per kilogram. And as they're trying to set up the equipment, the neonatologist says, why not just use the diving reflex? Get a bag of ice, put on the child's face, allow them to still breathe while you're doing this, and it worked. Boom, the heart rate plummeted, the child was saved. NRP may not help you with tachycardia, so consider broader differential diagnosis, call for help if you need it, and be able to manage and recognize supraventricular tachycardia in a neonate.
Don't forget to sign up for our Toronto course in the fall, and all of our dates for 2023 are coming up soon.
Welcome to CFP Distilled. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
We are co-founders of the Review Course in Family Medicine. Every year we go coast to coast across Canada and help residents and practice-eligible candidates prepare for the CCFP exam.
You asked for it, podcast. That's what people have been saying over the past year, so we're doing it. We're switching from YouTube to superstar podcasters.
Exactly. So this is CFP Distilled. What do we do at CFP Distilled?
Every month we take the CFP Journal, distill it down to what you need to know when you're practicing clinical medicine, and most importantly, for the exam.
So let's dive right in and take a look. Let's start with July 2022 CFP Journal. What are the most clinically relevant articles that we need to know for the exam and for clinical practice?
So the first one is the self-BAT, and we're not talking about baseball here. It's the bleeding assessment tool.
All right, so step up to bat and let's take a look. The BAT and the case that they've got here is a 22-year-old person comes to your clinic and says, doctor, I filled out the self-BAT screening tool and it was positive. What do I do now?
First thing you do is quickly turn on your podcast, Google, figure out what the self-bat is. So it's a bleeding assessment tool. And there's two numbers you need to remember. It's greater than 4 for males and greater than 6 for females. So if people have that as their score, that's when you need to start thinking about investigations.
Exactly. So what kind of tests would you order? And that's a really important thing we need to know for the exam. That would make a great SAM question. What tests do you order for someone who needs to be screened for a bleeding disorder?
CBC, done.
Absolutely wrong. So I know in real life that's correct, but as you know, if you've been studying for the CCFP exam, CBC is not an acceptable answer. If you go to the reviewcourse.com/exam essentials, you'll find all the instructions that say what you can and can't answer on the exam. So what should we write instead on the exam?
We're going to write hemoglobin. We're going to write the specific indices that you're looking for. The article has a great PDF. It's a 2-pager that you can print out, great for reviewing, say, the week before the exam.
There's a couple of other tests we're going to order as well. Ferritin, activated partial thromboplastin time, and the prothrombin time.
What are some of the diseases we're thinking about? Von Willebrand's disease. Who can spell von Willebrand?
I think von Willebrand probably could spell it because it was
His
named
entire
after him.
family could.
Exactly.
But don't worry about spelling on the exam. If the examiner can tell what you're trying to spell, you're all good.
All right, and then management, it depends on the cause of the bleeding disorder, depends on the type of bleeding disorder. The infographics got it also, make sure you take a look at that. Let's move on to the next article, erythema multiforme in kids.
That is a great one and a complex one and a difficult one. The thing I always want people to remember at the CCFP hospital, right, when you're writing the exam, is you've got to keep a big, broad differential and make sure you rule out the deadly stuff. So any skin disease, you want to have a good, deep differential.
So again, could be a great SAM question. What are the differential diagnoses for someone with erythema multiforme? Think about the can't miss diagnoses, the fatal diagnoses. They've got 2, toxic epidermal necrolysis and Stevens-Johnson syndrome.
Yeah, so you want to remember those. Some of the clinical things that you want to look for is, are there pustules, are there blisters? And think about not only the skin, but systemically. How is the patient? Do they have a fever? Do they look sick?
Exactly. So if somebody's writing a question for the exam and they say, what causes erythema multiforme? What causes these target-like lesions that you see on the patients? Well, there's several things that you could be able to write down.
So you're going to start off with viral. HSV1 is the most common, could be HSV2. What is something that you don't want to miss, Simon? Maybe someone's been taking something from the shop.
A couple of other viruses, cytomegalovirus, Epstein-Barr virus, influenza virus. But no, I have no idea what your leading question is there. What kind of things do people take from the shop?
They go to the pharmacy, they had a bit of a sore throat, and they took some NSAIDs. So it's medication related. So could this be erythema multiforme that is caused by some sort of medication triggers? It could be NSAIDs, could be anti-epileptic medication. So really important to get a medication history from your patients and find out, is there anything over the counter that they started to take?
2 other important causes to know about: vulvovaginal candidiasis and mycoplasma pneumonia can also cause erythema multiforme. And you do want to take a look at the picture of the rash. So could they ask photograph questions on the exam, and how do we know that?
Sure, why not? Because when you do the practice exams online from the CFPC, you will see some images. So be prepared for images. I think, Simon, you're working on an amazing new derm resource for this.
Exactly. If you're part of our Facebook group, then you'll see the news when that comes out. All of these links that we're talking about, the practice exams, the old exams, what the exam software looks like, and also the Facebook group can all be found at thereviewcourse.com/exam essentials. Should we move on to the next article?
Sure. Let me take a sip of this water here.
Ooh.
You ever had podcasts for weight loss?
So relevant. So relevant.
Oh, that is delicious water. It's like clinical trial water.
Water for weight loss. Well, in one of these clinical trials, they actually provided water 2 to 3 liters a day to the participants to find out, does it help them lose weight?
Probably if you're carrying 2 to 3 liters of water around, that probably helps. I don't know if they control for that.
They did not control for that. There you
No,
go.
there you
Poking
are.
holes in the CFP Journal.
Yeah.
That's what we do. So I guess the bottom line question is, does increasing water intake lead to weight loss?
So these studies don't hold water. So if you're the only interesting kind of piece for this to me was drinking, like preloading with water, which is interesting. So before you go sit down, have your big steak dinner, maybe you're doing keto, whatever, drinking 500 milliliters of water before you eat. So basically creating early satiety. Maybe that has an effect. Otherwise, not great evidence for it. That being said, your renal function is probably gonna be pretty good.
Not bad, yeah. So the bottom line for that, improves weight loss maybe by 1 to 2 kilos over 3 months if you give the folks 500 mils of water before a meal.
That's easy enough.
One last article, and this is an electronic article, so it is not in the print edition, but it definitely worth reviewing and definitely worth knowing. And this one's really vital for things that a lot of residents and practice eligible folks aren't quite as strong on. And we're talking geriatrics, care of the elderly. There's definitely a 105 topic on this. So what do we need to know from this article?
You've got to look for polypharmacy and then be able to take it that next step. So what can you cut down? What options can you give to your patients? So the first part of it, as I mentioned, is how do you decide? What sort of criteria could you use? If you were to create a question, Simon, what would you say?
Yeah, so there's explicit screening criteria. We all know about the Beers criteria. Interesting fact, Beers never became a geriatric because he died in his 50s.
Oh, did he choke on too many pills or something?
Probably not, because of the Beers criteria.
I wonder if all these people apply their rules to themselves. Who knows? The other thing you can use is stop start. So this is a little bit newer, something to look up in preparation for your exam. I think I would say pick one of the two, because essentially it's going to give you a framework, an idea about how to answer the question, how to look at that SAMP stem and break it down and say, these are the issues and these are the medications we could potentially stop for these patients.
There's another great tool they talk about called the Medication Appropriateness Index. Great mnemonic. And then finally, when we teach the Snowflake mnemonic at the review course, there's always a resource that you can use when you refer, especially when it comes to pharmaceutical overload, polypharmacy. Where could you refer this patient?
To the pharmacist, community pharmacist. It's often overlooked on the exam. When you think about who's a part of that clinical healthcare team, you can refer to a clinical or a community pharmacist to help that patient manage their medications. And don't forget something simple like combination therapy. If they're on 2 antihypertensive medications, put them together, give them 1 pill, easy mark.
So we've talked about the self-BAT bleeding assessment tool. We've talked about erythema multiforme, target lesion, and the differential diagnoses.
Water for weight loss and polypharmacy in the elderly. So 4 things, now you know them for the CCFP exam.
August 2022 CFP Distilled. Let's take a look at the most clinically relevant articles from this month's edition. We are here in beautiful sunny Vancouver.
Beautiful, and just as beautiful as the cover. I'd give this month's cover probably like a 4 out of 10.
We've got a rubber tire and some, for those of you listening on the podcast, you can't see it. We've got some
rubber tire looking through at barrels at a garbage dump in
rusted
Nunavut.
Barrels. Beautiful Canadian landscape being featured on the CFP Journal. And we've just been busy for the last several days working on our annual literature review. So what do we do every single year for the review course?
Look through all 105 topics, check for all the new updates, and then distill it down for what you need to know for the CCFP exam.
Yeah, so we're so excited to meet you at our spring 2023 courses. We'll show you all those literature updates, but right now we're going to focus on the CFP August 2022. What are some clinically relevant articles we need to know? There's 3 different topics here. The first one is acute otitis media, definitely something we need to know.
I could absolutely see this showing up on a CCFP exam. It's also something that's going to come up commonly in clinical practice. So the updated guidelines from Infectious Disease and Canadian Pediatric Society, looking at kids from 6 to 2 years old. When do we treat them? How long do we treat them? What do we treat them with, Simon?
Exactly. So those are the key things to know. And there's also going to be curveballs that we need to know, because what if they are allergic to amoxicillin, the first line treatment? What are you going to give them? The answer, cefuroxime. What if there is treatment failure? The initial treatment didn't work. You're going to give them amoxicillin clavulanate. And when do we just treat and when do we do watchful waiting? So there's actually 3 criteria that you need to know, that you need to be able to write out on an exam and ask about on a SU, that you can actually use to diagnose acute otitis media.
So what are those things going to be? You're going to look for that bulging likely to perforate tympanic membrane.
You're going to look for an acute onset of symptoms. If you just see the bulging tympanic membrane with pus behind it and the kid is happy, well, no fever, no pain, no vomiting, no upset nature from all of these things, maybe it was an otitis media they had last month.
Yeah, so if they're in that 1 to 2 days, then you can do that watchful waiting. But if it's been 1 to 2 days, they're irritable, difficulty sleeping, then you're going to start to treat them. And how long are you going to treat them? 10 days.
Yeah, and just going back, the third key feature on diagnosis is going to be the effusion. So acute symptoms, middle ear inflammation, and symptoms. You need all 3 of those to diagnose acute otitis media. So, yep, you're right. Going on 10 days. That's the amount of time we need to treat. And what if you look in the ear canal or on history, you assume that the drum has perforated?
It's still treatment for 10 days systemically.
Exactly. So that's some key things to know about acute otitis media. Let's move on to the next topic on contraception. The next item to
Next
know?
item, let's explain it. Let's Nexplanon. This is how to
Nexplanon.
avoid.
Hold on, that's a
getting-
brand name. Can you use brand names?
You can use brand name and generic at the exam.
Okay, so if you prefer the generic, as I know you always do, you would use the term Nexplanon. Nexplanon. Okay, so it's etonogestrel or Nexplanon. One of the things that patients are going to ask us about and would make a really good SAMP is, should I choose the Nexplanon or should I choose an IUD? And this article really lays that out really well.
So there's a huge thing you need to remember for Nexplanon. There's no evidence for patients with obesity. They were excluded from the trials on it. But what did the trials say for those that were included? So the one thing that's really interesting for me is, and it's easy to remember because you're putting it in the arm, is people would get paresthesia or some numbness in that arm. So if you were to counsel your patient, that's one risk you're going to talk to them about.
So that's the most common side effect that happens during the installation, the implantation, and then
Implanoning.
the implantation. So the next thing to know about are down the road. What are folks going to be complaining about, upset about? Because the satisfaction rate for IUD is about 80%, and for the Nexplanon, it's only about 66%. So what are they complaining about?
So they're complaining of amenorrhea and
Acne.
Yeah, that was another one. And a discontinuation rate. So they actually stop using it. And remember, how long can you use it? It's only 3 years for the Implanon, then you have to have it removed, which can be tricky, and you have to have training before you do it.
Yeah, exactly. So I know that there's a training tool that you can learn how to implant these at home.
Yeah, to implant, they'll actually send you a kit where you can kind of go through, and now you have to be careful with this because there are sharps in there. I'll be honest, I was opening up the scalpel doing the training. Glad I did it at home because I nicked my finger. So I'm glad I used the training tool. They send you kind of a mini arm and you can put it in and return it back to them afterwards. So a great way to train yourself and then go watch one of your colleagues do one or two.
And last thing about the Nexplanon, cost versus the IUD, it's about the same. They say $310 for the Nexplanon, $370 for hormonal IUDs. But remember, the IUDs last 2 years longer, 5 years versus 3 for the Nexplanon.
Yeah, the cost is only a part of the picture. Remember, when you're talking to your patients, you want to be patient-centered, and you're going to have to say, well, you're going to come back 3 years or 5 years. So that's not financially accounted for, but that's more trips back to see you, more chances for complications.
Very good. And let's move on to our last article from the August 2022 CFP Journal. We've got asthma. They talk about the 2019 GINA guidelines, which are phenomenal because there's a massive update. Like, it's a game changer for asthma. You absolutely must know this key change.
So this is part of some of the studies, the Sigma study that came out. So Ventolin, like, I'm getting short of breath because I'm so excited about this topic. But if I was just to take Ventolin for my mild asthma, is that enough?
Absolutely not. So if you've got mild asthma, the new guidelines that came out in 2019 say Ventolin plus a scheduled inhaled corticosteroid. So morning and evening flow vent, or if you want to make things easier, more convenient for the patient, and more profitable for the drug company, then you're going to be doing SMART therapy. That's combined single maintenance and reliever therapy.
Boom.
SMART, not like
Smart.
us, apparently. That's the name of the treatment regimen. And it'll make a lot of money for AstraZeneca if you tell your folks, just use Symbicort. You don't need 2 puffers.
Yeah, so this is interesting. So this article in particular looks at one point, and I know there have been studies that showing this, like long-term steroid use will actually decrease height overall. I think it's 1 or 2 centimeters over the entire kind of growth trajectory of a child. So you can use budesonide formoterol. You can use that instead of using that daily therapy with steroids.
So budesonide, the steroid, is in SMART therapy in Symbicort, and formoterol is the long-acting agonist, but it's also a fast-acting, which is why you can use it for a reliever as well as a maintenance. One final key point from the asthma article is they've got table 1 on page 595 about control, and they've changed this over the years. Definitely key history questions if you got a SUE about asthma. Definitely things to know on a SAMP about asthma. You're going to be asking about daytime symptoms.
Is it a maximum of 2 days per week?
Yep, you're going to be asking them, do you need to use your reliever therapy?
Maximum of 2 doses a week, and includes doses taken before exercise.
Exactly, and is exercise affecting your asthma?
There you are, physical activity, we want that to be normal. Exacerbations, you want them to be mild and infrequent.
And that one's really interesting because there's no set number for exacerbations, and that's intentional. They validated this control tool using history from the patients. If the patient thinks it's mild, then they're well controlled.
And no absences from school, no getting out of school for COVID or asthma. going to school.
or work. And then the last one is 90% or greater of personal best of your peak expiratory flow. That's it for our August 2022 CFP Distilled. We want to say one last thing for us. We're really excited about spring 2023. Where are we going?
We're going to go Vancouver, Toronto. Is there any other city we might be going to? Because residents asked.
Calgary?
No.
No one asked about Calgary, but we're going there
Going
anyways.
to Calgary, but where else?
Las Vegas.
Las
We've
Vegas.
Had
Can't wait.
a lot of buzz, a lot of residents saying we need a destination review course. So after several years of running the course, we finally worked up to it. We've listened to the residents. We're going to do a Las Vegas course in January 2023. And there's an amazing promotion. If you take a look at the website, you'll see how you can go there for free.
Hope to see you there.
Signing off, I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon. That was this month's CFP Distilled.
Take care. It is great to be here. This is the September 2022 CFP Distilled. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
We are here to go through every clinically relevant article here in the CFP Journal. If you are a Canadian practicing family physician or if you're studying for the CCFP exam or both, we have got what you need to know, the clinically relevant tips, tricks, and pearls from CFP September 2022. So I see you're already halfway done.
I don't know. Most importantly, cover rating.
Cover rating. I know it's a bit of an odd one, a bit blurry here. I guess that's an artistic effect. I wouldn't understand that.
I'm giving it a 4, no more.
4. They got a stack
Four,
of
no
stack
more.
of CFP journals and the world on top of it with a clock.
Time is ticking for the exam. Should we dive in?
Let's dive right in. So what is the first article we want to take a look at here? It's about cardiovascular disease.
Cardiovascular disease, and what about it specifically? Investigations and some of the risk markers. Now, I'm not going to dive deep into that, like lipoprotein A, troponin. The real meat of this article is about when to start statins.
Yeah, so there's several indications when statins are going to be reasonable to start. And so if you know your patient has atherosclerotic cardiovascular disease, then you know straight up statins are indicated.
But so that's the first one. Next, we're going to talk AAA, greater than 3 centimeters, or any sort of aortic surgery that they've had. Boom, they're on statins. What else?
Exactly. People with diabetes, people with chronic kidney disease, statins are going to help reduce their risk of having a CVD event.
Chronic kidney disease is another indication.
I think I just said chronic kidney disease,
Did
but
you?
it is that important that we should say it twice.
Say it twice, because you got 2
Absolutely.
kidneys.
Yeah.
You have to have it in both.
And if you got an elevated LDL, so the guideline says if it's greater than 5, that's when you want to start a statin.
And then high Framingham risk scores, that's another one. So that's like 5 different things that you might have to write down on a SAMP.
Do you hear the next article is about what? Ear piercing?
Ear piercing.
If you've got a left field SU, this SU comes out of nowhere, or a SAMP question, you're like, what are they talking about? Ear piercings? What are the complications? It's a totally reasonable SAMP question because it was in the September CFP Journal. So what are the complications of ear piercings?
So the first one was wild, and now like I still have my ears pierced for med school, but embedded earrings, so they can get embedded and stuck in there is the first one. I wouldn't have thought of that if I didn't read it in the journal.
If they've got ear piercings, they can end up with keloids and hypertrophic scarring.
Next, a nickel allergy or an allergy to the metal contained in the earrings. If you've got someone who's come in, has a new piercing or new contact, a contact allergy.
And finally, auricular perichondritis, very serious disease. It can be destructive to the cartilage in the ear. You want to know your bugs, especially for any microbacterial illness. What are the bugs that cause perichondritis around the ear? You're thinking about Pseudomonas. You want to cover those with your floxacins.
Floxacins, I love that.
That's the actual class
Cover your ear
name.
in floxacins.
Cover the ears
Love
with
it.
floxacins, with your fluoroquinolones. What is the next article about, Paul?
It's rapid recommendations. So this is part 1
Faster.
of 2.
The
Wow,
rapid
it's too much. It's too
recommendations.
much. So additional therapy. And this comes back to that first topic that we talked about in this podcast. So what is your next line? What other drugs can you give? Now, not great evidence in this field, but is this something that you could be asked on the CCFP exam? Sure. So what else could it be? Ezetimibe or proprotein convertase subtilising kexin type 9, PSK9 inhibitors. Remember, you can use acronyms as long as they're commonly used and known across the country. So PSK9 inhibitors and ezetimibe. Commonly used in clinical practice, not necessarily, not really great evidence, but what's your next line after statins? What do you need to know? Those are the 2.
All right, so the next rapid recommendation is from a guideline from the CCS, the Canadian Cardiovascular Society. You got your patient with AFib. and they're on an anticoagulant and antiplatelet, there's another drug you should automatically think of prescribing. So what is that medication? That is a PPI.
Brilliant. Next, HFrEF. Heart failure with R, reduced ejection fraction. There's a bit of a word salad, a lot of letters. It's like teaching an alphabet to a kindergartner. What are the drugs that you need to remember for these patients?
It's amazing because this is so different than it was even just a couple of years ago. If you have not looked at heart failure guidelines recently, brush up on these. Your patients who are diagnosed with heart failure should be leaving your office with 4 medications. So what are those?
So beta blockers. What else?
Yes.
You want me to? Beta blockers, SGL2 inhibitors, mineralocorticoid receptor antagonists, and then either an ARNI, ARB, or an ACE.
Notice that a diuretic is not part of that standard therapy. So that's one of the major changes there. Moving on to asthma.
Asthma, well-controlled asthma. Patients who experience daytime symptoms 2 or fewer days per week, or need 2 or fewer reliever doses per week. And what about those that are at high risk for exacerbation, Simon?
Yeah, those are the people who should be getting an inhaled corticosteroid, an ICS. If you're high risk for asthma exacerbations, think about prescribing those inhaled steroids.
This next one is quick and dirty, but it's challenging to implement. And I think a lot of people have an emotional reaction to treating diverticulitis with
Antibiotics.
No.
Antibiotics.
No.
Always use
No,
antibiotics. Are you going to tell me
no.
that everything I learned in medical school is wrong?
Treated without antibiotics. And this one, I still find this one challenging. I've tried it a few times, but you can just give some anti-inflammatories. Now, these are these early cases, and you get into this weird clinical conundrum where you're like, do I image them first before I decide to or not? But you can treat diverticulitis without antibiotics. We talk about game changers all the time, but I think this is one that could potentially be a game changer going forward.
Yeah, these patients used to be admitted. They used to be getting high-dose IV antibiotics, and then it was oral, and now we're saying no antibiotics is reasonable. Now, when it comes to sinusitis, we know our patients are begging us for the antibiotics. We used to give 10 days of amoxicillin. What do the new guidelines say for that?
Let's bring that down 5 to 7 days. 5 to 7 days for acute bacterial rhinosinusitis.
Let's change gears. We're going to move on to an article on concussions from the September 2022 CFP Journal. What do they have to say about concussions?
Well, I catched a little mistake here. So this is interesting. So we know that CATCH2, we teach it at the review course. It's the latest evidence. So CATCH2 is our kind of latest validated rule to figure out, do we need to image kids? We've had a big knock on the head. So CATCH2 added in greater than or equal to 4 episodes. Episodes is key here, episodes of vomiting. The article here talks about using CATCH. We want to be using CATCH2, the latest evidence and our latest tool, to be able to tell us, do we need to image these kids inappropriately or appropriately with CTs for head injuries?
Catch 2, what are you going to do? You're going to move on to the next article on seasonal allergies, patients who have allergic rhinosinusitis. So immediately, 2 classes of medication should come to mind: antihistamines and inhaled or spray steroids, intranasal corticosteroids. So let's start with the antihistamines. What do they say about that?
So this is interesting, 10 to 30% improvement in symptoms. I was like, okay, sure, allergic rhinosinusitis probably dries things up, but what gives something a little bit better? What's our next step?
Yeah, so more patients achieve control of their symptoms if you give them an inhaled corticosteroid, an intranasal corticosteroid. These are the nasal sprays, the steroid sprays. Warn your patients. These can lead to headache, they can lead to nosebleeds in about 10% of people. But compared to the antihistamines, they do a better job. You get 80% improvement with the steroids compared to only 60% improvement with the antihistamines.
There you have it. An amazing month, lots of content. We look forward to you guys listening and watching next month. But what's this? That's not a CFP journal.
This is not a CFP journal. This is one of our craziest ideas we've ever come up with. This is a study tool. And now I know what you're saying. You're thinking, this looks like a children's book, right? No, this is a study tool for the CFP exam.
It's a study tool secretly camouflaged as a children's book.
So in the back, you'll see every single page has got multiple exam tricks, tips, and habits. One of my favorite examples in here, let's flip to that page with the child who's got a cast on his leg. And you look at this kid and you're like, oh my gosh, this kid is preambulatory. He's not walking. Why does he have a cast on his leg? You got to think about
child abuse,
non-accidental injury. So the entire book is filled with little pearls like that you need to know for your exam, but it looks like a children's book. So you can actually study for the CCFP exam while reading bedtime stories to the little ones in your life.
Spend time with your kids and study. There's nothing better.
Fantastic. Thank you so much for joining us for CFP Distilled September 2022. We'll see you next month with October 2022.
See you then.
Welcome to the October 2022 version of CFP Distilled. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
We are here to talk about the most clinically relevant and exam relevant articles from the CFP Journal this month. Let's start, as we always do, with our cover critique.
Huge improvement from last month. Last month had way too much going on. The world, the paper, people facing all of our blurriness. This time we have a small infant turning to a ghost, turning into, I don't know, like a 6-year-old on a hopscotch. I think much cleaner. Not really sure if the yellow and blue colors work together, but much improved. I'd still only give this a 6.
6 out of 10. All right, I get track and field. That's about it. Let's dive in. Elder abuse. If you haven't found it in your practice, that means that you're missing it in 4 to 10% of people. And what are the kinds of elder abuse that people should be able and ready to list on a SAMP exam or identify on a SU exam?
So I think about my spidey senses tingling, and you know something's wrong, but there's 5 domains. So there's this like web of neglect. So number 1, neglect. And then you're thinking about physical, psychological, sexual, and financial. And I think that sexual one is important to remember because we don't want to think it's happening, but it is happening. 4 to 10%, I believe, are the numbers of those that suffer from elder abuse. So think of that web and those different things. So neglect, could it be psychological, physical, sexual, or financial?
All right, so let's imagine that Paul is an elder. He's coming into my emergency department, and I'm noticing you've got an injury here, you've got an injury there, you've got multiple injuries. How did these happen to you?
I'm just really accident prone, Simon.
And when did these happen?
They happened a while ago, but there was this weird delay between when the injury happened and when I came in, so a time delay.
And you've been here over and over again, so right there, you should be able to identify for a SAM question what are 5 indications of elder abuse on a history and exam. So the first one being that the injuries are unexplained.
That there's repeated injuries.
Patients saying that they're accident prone or a history that suggests that.
That delay in time between the injury and presentation.
And the last one's going to be recurrent visits to the emergency department for repeated and similar injuries. And there's going to be a few things you might pick up on physical exam.
So they might have poor eye contact. They won't be looking at you. They could have fear of coming in. What about my personal hygiene state if I was that patient?
Exactly. Hypothetically, I mean, your hygiene is terrible. I'm glad that you dressed up for the part, but you smell really bad. Your nails are awful, and your bruises are healing in multiple different stages.
Yeah, so the bruises are inconsistent with that mechanism. So those are the things you're going to look for on physical exam. So loads that could show up in a SU or a SAMP at the CCFP exam and in your clinical practice. So don't miss this.
Another important thing to know about SAMPs is it's reasonable to answer none. And so that's always got to be in the back of your mind. Is that what they're looking for when they say which physical exam findings or which laboratory tests would you do in a patient with elder abuse? Is the answer none? Well, look closely at the CFP Journal article.
So according to the article, there's a couple of things that you're looking for. So are they dehydrated? Are you going to check their renal function? Now you can't write renal function, but their EGFR, their creatinine. Have they been abused? Have they been hit? Have they been lying on the ground and they haven't been lifted back up from bed? Do you need to check their CK? So there's a number of different things that you can look for.
And finally, there's an easy tool. It's called the Elder Abuse Suspicion Index, EASI. It's a validated screening tool to help you identify folks who might be suffering from elder abuse.
So have a look at the tool, have a look at the article. I think it'll be a great help in clinical practice in picking up these cases and providing a bit of evidence for your practice.
Next article is on vaccine safety. You need to know about special populations. Vaccine safety in pregnant, infant, elderly, the PIE method we teach at the review course. This CFP Journal article talks about another special population, those who are undergoing cancer treatment.
So really when we talk about PIE in that cancer PIE, the immunosuppressed PIE, so pregnant, infant, and elderly, a PIE approach, the other piece in that I is the immunosuppressed. It's a broad spectrum, is a broad kind of ingredient in that PIE. These are the ones you need to think about. The big thing I want people to remember is live vaccines. So if there's a live vaccine, you're going to avoid it in those that are immunosuppressed.
So if I was a SU question writer and I was trying to get a superior certificate mark.
A superior?
Putting the SU into superior certificates. Or maybe I'm hungry, I just want to put the soup into superior certificate. I'm going to make sure that I'm saying what else is going to be involved in management, not just vaccinating the patient, but who else should we be considering and recommending vaccination for?
We love to say at the review course, no patient is an island. There's someone else involved. So vaccination of the patient's family is now strongly recommended. So there's something else that you would advise the patient on for vaccination.
So the final article from this month's CFP Journal is another rapid review. We've got a whole list of rapid recommendations from Canadian guidelines that you need to know for your CCFP exam. So let's dive right in and talk about those with ureteric stones. If they've had a CT scan, is that adequate to diagnose it?
So Canadian Urological Association is saying, XR, what? Pause. Why? I go straight to CT KUB in my local center. But what are they saying? They're saying ultrasound, renal, and a KUB XR are the two investigations that you need. So if I was asked this question on an exam and I'm asked for two investigations, it's not going to be CT KUB. I'm going to follow these guidelines. I'm going to say these two.
This is national guidelines, and it's amazing because I know you're thinking they've got a CT. Just look at the Scout film, just look at the 3D view. But even with all that into consideration, the Canadian Urological Association found that if you got all that and you add on an KUB X-ray, you're going to increase your sensitivity at picking up these ureteric stones.
So now, caveat, real clinical practice, you're going to have to follow what you're doing at your local center and what you have available. You might not have ultrasound at night. So think about national guidelines. This is a national guideline, so think about that for the examination. And remember the context of the question you are being asked. The context matters, where you are matters, so remember that for the examination. What's next for sexually active individuals under the age of 30?
So you're going to screen them for chlamydia and gonorrhea once a year, every single one of them, according to the Canadian Task Force on Preventive Healthcare.
And now let's stick with that topic of STIs, pregnancy. That's a pretty solid sexually transmitted, it's not an infection. Maybe
Sexually transmitted condition?
Condition. It's not a disease, but if you talk to someone with 2 kids or 3 kids, it can cause some
there is some morbidity involved.
Some morbidity
yes,
involved.
Some parental morbidity indeed. So the fascinating recommendation here, it differs than some of your provincial guidelines. Those of you in Manitoba might say, we don't do this in our province, but the SOGC is saying all pregnant people should be getting a complete prenatal sonogram between 11 and 14
weeks. 11 and 14 weeks, those are the times to remember. SOGC guideline. Sticking with the SOGC, tissue selective estrogen complex, or TESC, and tibolone. It's a synthetic steroid, represent 2 progesterone-free options for treatment of post-menopausal vasomotor symptoms. So 2 things to think about. So synthetic steroids and TESC, tissue selective estrogen complex.
The next recommendation, also from the SOGC, about patients with vaginal atrophy. No, we don't call it vaginal atrophy anymore. They now call it genitourinary syndrome of menopause. So you know the first lines, those aren't even covered in this article, but you know that the first lines are going to be lubricant, because that can affect the pH and bring things back to normal and reduce symptoms. Topical estrogen, also first line. But at the CCFP hospital, on the SAM exams, you need to be ready for second line. So pause the video if you don't know what are the second line indications for genitourinary syndrome of menopause. We'll tell you those right now. What are they?
Ospenephine and prostanerone. God, they need better.
Prasterone.
I can't. We need to look up at some stage.
You need to pause the video. Pause the video.
Prosterone the video.
Not progesterone.
And remember that you can use trade or generic names. So hopefully they'll have some really cool, easy to remember name as well.
And let's wrap up with symptoms of depression. Your patient is 65 or older. Could you name 2 first-line medications for that patient?
So duloxetine and sertraline for depression. So what do you need to do? What do you need to remember to bring those patients up that are down? Duloxetine or sertraline for those that are over 65.
And now another special population. If they are perimenopausal, they have depression, what are your symptoms and what are your, outside of vasomotor symptoms, what is your treatment of choice for depression?
So the SOGC, to come back to them, so a load of new guidelines this year and a load in this journal is hormone therapy for those patients, irrespective of vasomotor symptoms. So if you've got a patient with depression, you've got to be thinking about hormone therapy as well.
So that's a wrap for our October 2022 review of the CFP Journal articles. Now, one last thing we want to mention. We hope to see you at the review course, spring 2023. Where are the cities we're going?
We're going to Vancouver, Toronto, Calgary, anywhere else?
Oh, that's right. We've been dreaming about this for years. You've been asking for it. Let's beat the Canadian winter. Let's go to somewhere sunny and hot in January.
Las Vegas in January. Kick off your studying. Be the first person in your program to have reviewed all the 105 topics in one weekend. Come join us in Las Vegas in 2023.
Viva Las Vegas. For CFP Distilled, my name is Dr. Simon Moore.
And I'm Dr. Paul Dillon. Until next month.
See you next month.
Great to see you, Simon. Great to be back. This month's CFP Distilled.
I'm Simon Moore.
I'm Dr. Paul Dillon.
Let's dive into the November 2022 CFP Journal and find out what are the clinically relevant articles you need to know.
What about the cover?
Oh, of course. We
What
always
about
have
the
to
cover?
start with a cover critique.
You know what? I think I really like that. I think they've got a little bit more advanced, it's still abstract. This guy doesn't know whether he's going east, west, or north, practice versus retirement, covering the entire spectrum. But let's dive into the 3 articles that we're going to talk about. First, we're going to talk about screening tests. How do you evaluate a screening test? Next is going to be a dirty topic, diarrhea, and
the final one that we're going to talk about, and I would say stay tuned for this one, practice changer. I'm going to use it in my clinic. Which antidepressant do you select? An amazing tool you can pull up at the bedside. So let's start with screening tools.
So screening tools, we all want to be like frequent adopters, rapid adopters. New screening test comes up, we want to use it, but we have to remember, what is a screening test for? It's essentially a sieve for a large patient population. So what do you have to ask yourself about your patient sitting in front of you before you start using a new screening test?
I can see this being a great SAMP question. They want to know that you know about clinical care, family medicine, but also when it comes to testing and good choices of screening tools. So what kinds of things should we study for our SAMs?
So a full body MRI for all your patients? Well, the answer is going to be no. You're going to think about the downstream effects. What are the possible harms? What are the possible benefits to your patient? There's a great box 2 in this article. That's the one to know for when you're studying for the CCFP exam.
Great article from Tools for Practice, an amazing group out of Alberta. They always look at the recent evidence, the recent literature, and come up with a bottom line for what do we need to know in clinical practice. So the first thing to know about this one is it's on diarrhea. Breastfed and formula-fed kids, if they get a stomach bug, they get diarrhea, what should we be doing when it comes to their feeding?
So there's a thought that, maybe we should hold back on any lactose-containing products. Not great evidence, I think, is the bottom line. The answer is maybe.
Yeah, the evidence, it's old, it's a lot of confounding factors, but we do know that if they are formula fed and they've got diarrhea, you want to cut back on the lactose containing formula. Switch to a lactose-free formula because that can shorten the duration of diarrhea by about 18 hours.
And 18 hours for anyone out there who have children, or maybe have experienced children with diarrhea, that is a long time.
What about the breastfed kids? Keep breastfeeding.
Let's get on to that one article you need to know from this month's CFP Distilled, and I've bookmarked it here. It's on antidepressants and a really nice one-pager, Simon.
Exactly. So we're going to put up on the screen this beautiful flow chart because we all know that people come to your clinic, they say, which antidepressant should I start on? And at the end of the day, the evidence says that they're all equivalent at improving depression symptoms. So what should we do when we're choosing one?
I think my biggest takeaway from here is to look at the comorbidities, and it's laid out really nicely because most patients with depression, I should say a lot of them, not most, will have some sort of comorbidity, and that chart really lays out how you can utilize your choice in antidepressant to work at those 2 problems together concurrently.
And let's take a look at page 2. If we put that up on the screen, you're going to see that there's other considerations, cost, can the pill be crushed? And these things are all going to come into mind when you're trying to select an antidepressant for your patient. A couple of really good examples. Patient with stress urinary incontinence, there's a specific antidepressant that would be a better first-line choice for them. So take a look at that. Chronic pain, cardiovascular disease, it's a fantastic tool. Definitely going to use it in my practice.
That's it for this month.
Make sure if you're studying for the CCFP exam, take a look at the reviewcourse.com/exam essentials. There's all sorts of stuff there. You need to know what kinds of things can we find there.
You can find links to places to go study, to look at the SUS online, to look at old resources, and look at all of the resources peer-reviewed across the country just for you.
Spend some time learning about the software, what it's going to look like on exam day. So on behalf of the Review Course in Family Medicine and CFP Distilled, I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon. We'll see you next month.
Welcome to the December 2022 CFP Distilled. Whether you're listening on podcast or video, my name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
So let's take a look at the clinically relevant articles from this month's CFP Journal and also bonus tips if you're studying for the CCFP exam.
Coming up in only a couple of months for a lot of you out there. It's great that we're getting to the end of the year. We're going to have a great summary of all of this important information, all of the CFP Journal summarized.
Before we do that, we always start with a cover critique. This is a tradition that we've started, and Let's take a close look at this maze. I mean, it's pretty dreary.
It's very dreary and dark. I don't know if I would put this at the end of the year. I'd want a little bit more of an uplifting one maybe next year. They probably don't listen to us.
Light at the end of the tunnel, maybe that's supposed to represent hope. Anyways, there is hope if you are studying for an exam, because we're going to summarize these things succinctly. What is our first article, Paul?
The first one is about spinal cord injury and some of the complications that might arise from this. So we're thinking about spasticity, we're thinking about UTIs and pain. So those are the three big things to wonder about considering these patients. Great article, short article. The biggest thing to take away from this one is actionnuggets.ca. So this is an app that has the 20 most common issues that may come up with spinal cord injury and what to do as a family practitioner.
Moving on to UTIs in the broader population, something we see all the time. What are we going to do for those folks who come to us and they ask for prophylaxis? What can I do to prevent UTIs? And again, if you're studying for a SAMP or on a SU and you want to have management tips, this article is great because they look at the evidence, but they also talk about the non-pharmacologic and the pharmacologic management. So some non-pharmacologic tips: increased water intake, as well as if you're postmenopausal, thinking about things like vaginal estrogen and vaginal lubricants. So that can be given as a ring or cream when you're giving that estrogen. So when it comes to the pharmacologic management, what does the antibiotic prophylaxis do? We don't know what the best one is yet. We don't know the best regimen. Things might include something like trimethoprim sulfamethoxazole, but we do know that it's going to reduce your incidence of UTI. We're talking about going down from 66% having a UTI if you're on placebo, down to 12% if you are taking an antibiotic prophylaxis.
Now let's move on to children. We've talked about spinal cord injury, we've talked about UTI prophylaxis in non-pregnant women, but what about those newfangled pumps? Remember when type 1 diabetes was a death sentence? Well, they've taken the die out of diabetes. We've now got insulin pumps. But what can happen with these? What are those complications that you might have to manage as a family physician? So great, once again, 2-page article that talks about some bubbles. What do you do about that? Big things you need to worry about: skin complications. Is there tunneling in adolescence? Is there an infection at the site? So great article to just quickly read up on what are some of the common complications with these new diabetes pumps.
And let's wrap up with a new mnemonic for your delirious patient. We all learned about DIMS in medical school. So drug, infection, metabolic, structural. What do they add to this new mnemonic?
So they've made it DIMS 5. So let's get that up on the screen and let's walk through it.
So as we go through the DIMS plus 5, the first thing is going to be pain. And then the next is going to be intake and output. So liquids and solids.
Urine and bowels. And then we're going to talk about the senses. So senses, sleep, setting, stasis, and stress. So we've expanded DIMS 5. There you have it, DIMS 5 plus the senses.
And there's a great box 1 in this article. I would take a close look at that. If you're studying for SAMPs, you want to investigate these folks. Which testing would you do to investigate? Now, with all due respect to the guideline author here, they probably would fail a SAMP on this. Why is that?
Well, in the list of recommended tests talks about CBC, it talks about a blood gas, but we know at the CCFP hospital, like we teach at the course, you've got to be specific. So that you can't write CBC, you've got to write the specific indices, you've got to write hemoglobin.
So wouldn't it be great, Paul, if there was a way to quiz ourselves and test ourselves on this content from the CFP Journal, from all of 2022? Is there a way I could get practice SAMP questions from the CFP Journal?
This is what we've done year after year. We've created a SAMP, a practice SAMP, where we've taken all the clinically relevant stuff out of the CFP Journal, distilled it down, turned it into SAMPs, and I'm so excited. It's such an amazing product. Every year people love it. It is tough, but you get the chance to review all of the CFP articles made into SAMPs once a year. So the national SAMP is coming out in January.
So go to thereviewcourse.com and take a look at the products we've got there. And what we're talking about right here is called the 2023 National Practice SAMP. So on behalf of the Review Course, I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon.
Take care.